Closed captioning for Lakeland Currents is supported by the Minnesota Department of Commerce, Telecommunications Access Minnesota, and Nisswa Tax Service. Nisswa Tax Service, tax preparation for businesses and individuals. Across from City Hall in Nisswa and online at nisswatax.com.
It's been estimated in America that about 15% of us are suffering from some form of depression. That's a pretty significant number. And so tonight our program is about diagnosing and treating depression, identifying what depression actually is. And my guest is Dr. Stephen Grant, who is with Lakeland Psychiatry Clinic at the St. Joseph St. Joseph Medical Center here in Brainerd. Welcome to the show, Steve. It's nice to have you here.
Thanks, very appreciate you having me on tonight.
Maybe we could just talk, maybe to start out with, what is depression? I mean, I know there's not just a single form of it, but could you help us understand what some of these forms of depression actually are?
Sure, absolutely. A lot of times when people think about depression, they think depression is just sadness. You know, it's just that kind of, oh, I'm bummed about things, and people say, you know, why don't you just snap out of it? Why are you so sad? And the reality is sadness is something that's a natural part of our human experience. You know, everybody experiences sadness when they, you know, if they lose a family member, if they have a relationship breakup, if they, you know, lose a job or something like that. It's an emotion that comes and it passes. Depression, on the other hand, is a disease that typically doesn't go away, at least not quickly, without some sort of involvement, and also has a pretty significant impact on people's lives. You know, we think of, you know, sadness as just being an emotion that comes and goes, whereas depression can impact sleep. It can impact their ability to enjoy things. It can impact their ability to work. You know, there's lots of aspects of people's life that are harmed by depression, actually. And it's important that you know, we treat it, because if we don't treat it, there can be a lot of negative consequences in people's life. And so that's.
I know that it can hit all ages. What are some of the earliest ages that it's actually been identified as an issue?
Okay. Well, I can, you know, tell you just from my personal experience with some of my patients. I have had patients that tell me that I don't ever remember a time where I was happy or I wasn't depressed or sad all the time. You know, that's something that is typically unusual, or can be unusual, I should say. But there are, you know, bumps of depression that happen pretty frequently after puberty during the teenage years. They can happen in midlife, and there's another increase in frequency that happens in later in life, when men in particular, when they retire from work, when they you know, have had their identity in their job and what they do, and then all of a sudden that's gone, you know, they get depressed. Also, if they lose a spouse, that's another thing that can definitely cause a depression.
Have you found in your work that it's hard for people to admit that they're depressed?
Oh, absolutely. Yeah, I think there unfortunately happens to be a stigma associated with mental illness in general, but particularly with depression. You know, people you know, have been taught from a young age that, you know, you need to be tough, you need to pull yourself up by your bootstraps. And unfortunately, one characteristic of depression is a lot of times people are unable to do that. You know, they lack the motivation, they lack the will, they just lack the ability to do that. So.
It's not necessarily a skill, so it's something that you need help with.
Oh, absolutely, absolutely.
Just talk a little bit about where you work. You work in a clinic in the St. Joseph Medical Center. It wasn't that many years ago, I think it was unusual to see psychiatrists actually working in a medical hospital. It seemed like that, and we had a lot of our country's history where they were separated, had their own facilities, their own buildings, but it's really becoming more entwined into the hospital setting, isn't it, where you actually have psychiatrists on staff to help, I suppose, after surgeries even?
Absolutely. Well, you know, historically there have been psychiatric hospitals that have been a component of the general hospital. But in the last, you know, 30 years or so, the biological basis of depression has been taken a lot more seriously. And with that, when we recognize that there are medications that can be used to change the chemistry in the brain that can treat depression, I think that it has gotten a lot more widespread acceptance in the medical field in general.
And you said something a little earlier before we went on air, that it's easier now for people to have this diagnosis and treatment of depression covered by insurance. It wasn't that long ago that a lot of people didn't have insurance. I remember reading one study, it said where some people were putting $13,000 and $14,000 on their credit cards because they had no other way of dealing with this financially.
Correct, and actually we can credit Paul Wellstone for that. That was one of his real kind of passionate things, was making sure that mental health coverage was paid for, just the same as people having to go to the doctor for diabetes or high blood pressure or something like that. And that's important because, as you mentioned, there's a very large percentage of Americans and people in the world in general who suffer from depression. As you said, at some point in our lives, approximately 15% of people will experience some depression. And that, just put that in perspective, that's about the same amount of people that will have high blood pressure at some point in their life.
Wow. And how often does it occur that people become depressed and they also become suicidal and actually do something about it?
And actually attempt suicide or
actually kill themselves?
Or actually kill themselves. I'll be honest, I don't know that number offhand, but it is very frequent. They look at the number of people who have committed suicide, and if you look back behind that, there's a pretty significant number of those who have been treated for a mental illness in the past, not only depression, but also things like bipolar disorder or schizophrenia. Oftentimes, chemical dependency, if that is involved, can make the suicide rate quite a bit higher as well.
I know, having worked in a college setting, that it was not uncommon to see young people so depressed that they would start talking about suicide. And I guess the thing that we were always taught is if they're talking about it, they need help. Mm-hmm. Don't ignore it. Would you say that's a good clue that something serious is wrong?
Well, I agree, absolutely. If somebody's talking about suicide, you want to make sure that you engage them and refer them to somebody. And a lot of times what happens is people will, a friend will be afraid to tell anybody about a friend who is suicidal. They don't want to push them over the edge or something like that, or they don't want to ask them questions about suicide with the idea that if I start asking about suicide, is that going to put the idea in somebody's head and then they'll actually commit suicide? And what research has shown is that actually that's not the case, that if somebody is suicidal and you ask them about it, they're not more likely to commit suicide. If anything else, they're actually less likely to, because they have someone who knows about it and someone can help them get help. And we actually pretty strongly recommend that people get professional help and people who have been trained in what specifically to do in those situations and how to recognize how severe somebody is and what to do about that.
I have a list here, and we certainly won't go through all of them, but maybe you could just give us some of the signs and symptoms that are signals to people that this person is having depression problems.
Sure, absolutely. So, the most common symptom that people think of with depression is that sadness, that they're feeling sad. And as I say, sadness and depression are not the same thing, but sadness is a very strong component of depression. Another thing that happens very frequently is people lose the ability to enjoy the things that they normally enjoy doing. We use the word anhedonia to describe that. So, typically somebody, say they enjoy going outside, spending time, fishing, hunting, obviously we're in Minnesota, that's something that's very popular. If you notice changes in behavior in your friends, that they don't want to do the things that they normally like to do, if they isolate themselves, that's definitely a symptom of depression. Changes in appetite. Typically when people become depressed, they have less of an appetite, but in other folks, they actually will eat more. So that's a very common symptom of depression. Sleep disturbances, both sleeping too much, not sleeping enough. Inappropriate feelings of guilt. When people are feeling depressed, a lot of times they will blame themselves for anything that happens. Regardless if it's their fault or not, they'll just assume that they must have done something wrong. You mentioned suicidal thoughts, suicidal comments. That's something that is a very, very common symptom of depression. Just because somebody has a thought of suicide doesn't mean they're going to act on it. In fact, most people that have the thoughts don't actually act on them, but that is something that we take very seriously. We want to make sure that we are available for people and making sure that they're kept safe. Other things we can look at are if people seem more agitated than before, if they're active, they're real irritable. That can be one thing, or it also can be the other way if they just don't seem to care, if they just kind of stop interacting. Those are all very common symptoms of depression.
And that is one of the things that I found interesting: anger and rage. Mm-hmm. It doesn't seem to connect to being feeling sorrow, but it's mm-hmm. just almost the opposite feeling. But it can be a symptom of the same problem.
Absolutely, absolutely.
Wow. Another thing that I found interesting here in the list that I had is not meeting expectations, or feeling that you can't meet expectations of mom and dad or your business or whatever. Is that something you see often?
It is something we see, and a lot of times it's actually an inappropriate feeling that they're not meeting expectations. They may actually be meeting the expectations, but for whatever reason they're thinking that they're not, and they're feeling inappropriate. Sometimes people become very sensitive to criticism and may take things to mean more than what they do. So.
Trouble sleeping, you mentioned a little bit about that, but how about also perceived aches and pains or illnesses that really don't exist? Is this something you see a lot?
Absolutely. There's a lot of physical symptoms of depression that, if people can get anxious, they can have some stomach upset. They can have some nausea or vomiting. That is something that can occur with anxiety. Aches and pains, muscle pains, some of that can come from not sleeping well or being uncomfortable, or that can all circle in that. But absolutely, there are what we call somatic symptoms of depression. That means, part of the body's feeling things. So.
Okay, so I'm having these problems. I walk into your office. Do you lie me down on a couch and start asking me questions?
You know what? I don't actually have a couch that
okay.
I use, but we definitely talk. And we, the first time I see somebody, typically I screen for lots of different things. I ask a lot of questions. I typically like to hear just the story. What's going on. We talk about depression and where it comes from. One thing that is common with depression is it doesn't necessarily make sense. It makes sense if somebody has their spouse die and that they feel sad, but what is it when somebody's sad for no reason, and that's something that can happen with depression. I'll ask them about their past. I'll ask them, is this something that's been your whole life? Is it something that's new? Have there been new stresses? Have there been new changes? And, another thing we also assess are the habits that people have. Unfortunately, a lot of chemical dependency types things can cause some depression. So if people are drinking a lot of alcohol does change some of the chemistry in the brain and actually can make people depressed. Marijuana is very, very, a lot of research showing that can make people depressed if they're smoking a lot of marijuana. So
really,
yep.
It's it interests me, especially in California, that there's this movement to legalize marijuana. Mm-hmm. And I've always found that really interesting from a medical perspective because of what a lot of the research mm-hmm. shows is the damage that can be done to people. Even it's connected quite often to brain cancer if there's a long extended use of it. So mm-hmm. I found it interesting that governments actually would be moving in the direction of legalizing it for pleasure, not just for medical purposes.
And this is a whole separate topic that
right.
I'm sure you could have a whole show based on,
right.
on the positives and negatives of marijuana. But myself and my personal experience as a physician working with people that have had problems with marijuana, I definitely don't see marijuana as being a benign drug. I see it as being a very significant problem. And, I have patients that I have tried on lots of medications and they just don't get better. And, every time I see them, it's like, we can keep trying medication changes, but until you stop smoking pot, we're probably going to get any better. And so, it is a complicated issue, but at the same time from my perspective, and I obviously have my own biases and that kind of thing, but I definitely steer people away from the use of marijuana.
So when you go through the process of trying to identify what is causing the problem, mm-hmm. I know there's been more and more research into the chemical imbalances in the mm-hmm. human body. Mm-hmm. How do you get to that level where you can actually tell if this is something that's chemically wrong with them or if it's something that's other than that?
Okay, and that's a really great question, and I think it kind of can look at, or it brings into light some of the debate that's been going on in the past, and it is that whole nature versus nurture. Is depression a chemical thing? Is it something that's due to circumstances? And the idea in the past was, if somebody is depressed and it's due to their circumstances, then maybe you would use therapy as a means of treatment, whereas if, for example, somebody has a whole family history of a lot of people with depression, that would lead us to believe that perhaps there's a genetic component and a chemical dependence, then okay, maybe in that situation that we would use medications to treat. What research has shown is that actually when people undergo stressful situations, that can cause physical changes in our body, including changing the chemistry in the brain. I mean, you think of if you get stressed out, if you're nervous about something, your heart rate goes up, your blood pressure increases. Those are physical changes that happen. It makes sense that there are other chemical changes that could happen as well. They have also done some research that has shown that if you use therapy, psychotherapy, if you can teach people coping skills, if you can, one of the outcomes of psychotherapy is that brain chemistry can actually change itself. And so what we typically do when we see somebody for depression is, and look at what are the treatments, the best treatment out there is a combination of both psychotherapy and medication in most cases.
I was listening to the radio on the way in tonight, and one of the things they said is the institution of marriage going away in America. And they said there's two good reasons why it shouldn't. One is that men physically do better when they're married, and women mentally do better when they're married. So that's, but at the same time, our country is almost 48 or 49% single now, which is the highest number it's probably been for forever and ever and ever. When you work with depression, do you find there's a difference between people who are single and who are married in their mental health?
In some ways there is. One thing that particularly came up is when we look at somebody who is depressed and we look at their risk of suicide, if they have a partner that is actually a protective factor and that makes them actually less likely to commit suicide. If we look at who are some of the highest risk people for committing suicide, we look at elderly people who have just lost a spouse. They're at very high risk of suicide.
Well, how about what are some of the initial treatments that you have? I mean, I know you talked a little bit now about medications, but what are some of the other things you do to treat people?
Sure. There's lots of things that we can do to help depression, help people to feel a little bit better about the things that's going on. You know, and a lot of it too depends on what is the degree of the depression, you know, and we also look at the preference of the person that we're seeing as well. There are people that, you know, would prefer to try to avoid medications at all costs, and, you know, that's something that's absolutely reasonable, you know, in certain cases. There's a type of psychotherapy called cognitive behavioral therapy that has lots and lots of data that suggests that it can be very effective. And the idea behind cognitive behavioral therapy is that our moods are often shaped by what we are thinking and these automatic thoughts that we have. When people are depressed, they tend to have thoughts that can be negative, or they can catastrophize things and have these negative thoughts. What cognitive behavioral therapy does is can put a little break in those thoughts that people have and help people to examine what they're thinking and see, are these horrible thoughts that they're having, are they based in reality, or is there, you know, some way of changing these thoughts so that, you know, maybe they can look on the brighter side of life. Or, you know, an example I like to use about thoughts being able to control people's mood, this was shared with me once before, is say, for example, you are sleeping at night and you hear a noise. Your initial thought of what you think that noise is going to have a profound effect on the mood that you feel. So if, for example, you hear a noise in the middle of the night, you think that it is a burglar breaking into the house, you're going to be, you know, frightened. If your initial thought is that perhaps this is the cat up on the counter knocking something over, you'd be probably irritated or annoyed. If you think, oh my, this is Santa Claus coming down the chimney with a load full of presents, you're going to be thrilled, you know. And so I think that's a great example of just the initial thoughts that we have in any situation can control our moods and how we feel. So,
and as you said, it's not unusual to have sorrow or a feeling of sorrow for short periods of time. What's a trigger? What tells people that they're having a problem? If they're just, how long should they go into that mode before they probably should seek help?
Sure, and you know, there's a lot of different questions or different answers to that question. If we look specifically at our DSM-4, which is our manual of diagnosis that we use, what they recommend is, or what technically is considered a major depressive episode, excuse me, is if somebody has, you know, 5 of these 8 symptoms of depression for lasting most days for a 2-week period is kind of what they recommend looking at. One way that I like to look at it, and I was having a conversation with Dr. Tom Greenspan, who's a relatively well-known psychotherapist down in the Twin Cities, just, you know, a few weeks ago, and we were talking about depression, and he made an interesting observation, and he said that he believes that the opposite of depression isn't happiness, it's vitality. And so living an active, interesting, you know, exciting life, that is the opposite of depression. So when you lose that ability to be actively engaged in life, that is a pretty significant symptom. Maybe this is depression and not just sadness.
We can't help but turn on the radio or the television now and see the ads, the commercials about vitamins, health foods. What does your industry feel about that area?
What is my take on that? Okay, yeah, and you know, we do, when we treat depression, we use antidepressants, we use medications. You know, there's a lot of research that's out on those medications. They are regulated pretty tightly by, you know, the FDA. what you get in the bottle is what is supposed to be in the bottle. You know, that's something that we can trust.
I was just, pardon me for interrupting, but when they do get on medications, is it typical that they stay on that for life, or is it sometimes just a short term?
Not necessarily. It's dependent on the person. You know, when we look at depression, if somebody has a major depressive episode, if it's untreated, typically it will last somewhere between 6 months and a year and a half. If we get people on medication, that treatment drops down to 3 months or so. There are some people, if they have, you know, a very significant family history of depression, they may need to be on medications for quite a long time. There are other people that don't. You know, we get people on, you know, medication, they kind of get through the tough time that they're going through, and then, you know, if they're feeling okay for 3 months, 4 months, 5 months, 6 months, then what I typically try to do is maybe come down a little bit on the medication and very gradually get them off it. You know, I am someone who very strongly believes that we should try to minimize medications as best we can, but at the same time, if somebody needs one, I want to make sure that they are aware that something's available to help them. Getting back to your question that you had asked before about the vitamins and the herbal supplements, there is a lot of good data out there about potentially some vitamins can be quite helpful. You know, one thing that we think of, especially here, those of us who live in Minnesota, vitamin D. If people's vitamin D level is low, you know, among other problems that they could be having, you know, depression is one of those. Vitamin D is, you know, a vitamin that's made by our skin in response to the sun. Here in Minnesota, we don't get a whole lot of sun, so it's pretty common that people have a low level of vitamin D. You know, I recommend most of my patients take a vitamin D supplement.
What do you recommend the dosage?
You know, it depends. I take it myself on occasion. I typically take 1,000 international units a day. If we do testing and if we, you know, see that they're low, sometimes we use a higher dose for a little while to get them up. The FDA recommendation is 600 international units a day. We do get some of that in our diet, but typically most of it comes from the sun. Another vitamin that I think is pretty important for people is the fish oil, or the omega-3 fatty acids. Very helpful for you know, high blood pressure, for cholesterol, that kind of thing. But there is some research out there that perhaps that can be helpful for depression as well. Folic acid is another vitamin that there has been some recent research out that is showing that perhaps that can be helpful for the treatment of depression. Folic acid is actually one of the components of the neurotransmitters that we know are affected in depression. So serotonin, norepinephrine, and dopamine are all use folic acid in order to create themselves.
Wow, that's interesting. Moving
on to the comment about the herbal supplements, there's a lot of things that are out there that you know, people market for depression. There's you know, St. John's wort, there's ginkgo, there's 5-HTP, there's SAMe is another one that's out and is popular. People do get benefit from those, but you know, whenever anybody uses an herbal supplement, one thing you have to remember is that they're not regulated by the FDA. The production's not regulated, and you don't always know what you're getting. You don't always know the strength of what you're getting. And one thing that's also pretty important to know is a lot of times people will take those supplements and just think that, oh, they're herbs, they don't really do anything. But in reality, a lot of times they can have a lot of interactions with other medications, antidepressants, certain medications used to treat, like certain anticoagulants like warfarin or Coumadin or those kind of things can have very strong interactions with those. So if somebody does take something like that, I think it's pretty important that they make sure that their doctor knows that they're taking it.
You also have a couple of other treatments that are probably outside the norm. One of them that you listed is ECT. Could you just explain to us real briefly what that is?
Correct. ECT, when people think, ECT is electroconvulsive therapy. And so what it is it's a very safe procedure that's done under general anesthesia. We use a very small electrical charge that induces a seizure that typically lasts between 30 seconds to a minute. The combination of the stimulus and that treatment can have a very profound effect on depression. Unfortunately, with ECT, most people think of ECT, they think of the movie One Flew Over the Cuckoo's Nest with Jack Nicholson, and that's unfortunate because, you know, that movie, you know, if we look at what's happening in that movie, you know, Jack Nicholson, I always say the wrong one. Nicholson is a criminal who's pretending to have a mental illness so he doesn't have to go to jail. They use this ECT treatment to punish him for acting out in this mental hospital. ECT is treatment that can be life-saving for people. And we were talking about this a little bit before. ECT is one of the reasons I decided to go into psychiatry. When I was a medical student, I was doing a psychiatric rotation, was at Regents Hospital in St. Paul, and had some very, very profoundly depressed patients, which were probably some of the sickest people that I saw ever through my psychiatric, through any of my medical school rotations. It doesn't matter what rotation I was on. These guys would go through it and they would get ECT treatments, and after a couple of treatments they would be normal. I mean, we'd be able to have a conversation, and you know, it was a pretty profound change. ECT has obtained, you know, somewhat of a reputation over the year too, especially when it initially was started. It can cause some memory problems, and you know, in the last 5 or 10 years, there's been a lot of advances that have really limited a lot of that. We have, I actually do the ECT at St. Joe's. We have a brand new machine that can cause, or that causes much fewer of the memory problems that have happened in the past. One thing I want to say about ECT is that it is actually the most powerful treatment that we have for depression right now. An antidepressant, any given antidepressant will work in maybe 65–70% of people that take it. ECT works in 85 to 90% of people. Really? And it works very quickly, and it works in things that, it works for people in things that haven't necessarily worked. So it is something that I am actually very passionate about in terms of the amount of good that I've seen from ECT has been amazing. And I get very frustrated with the stigma that's associated with it, because a lot of it is unwarranted. You know.
Unfortunately, we're running out of time. We're not going to get to the others that you have here, but it's a cutting-edge business too, isn't it? I mean, you're really seeing a lot of changes in your industry.
Exactly, and we look at the, you know, I'm just going to mention the things real quick that we had talked about. I think in the next 10, 15 years, the field of psychiatry is going to change significantly with transcranial magnetic stimulation, with vagus nerve stimulation, also looking at deep brain stimulation for the treatment of depression. Let me throw out one thing. There's a study going on down at the University of Minnesota with Dr. Barry Ripberg looking at deep brain stimulation, and hopefully there'll be some good things coming from that. So.
We've run out of time.
Okay.
Thank you very much for coming. It's a fascinating business, and if they want to get a hold of you, they can call St. Joseph Medical Center.
Absolutely.
Thank you for appearing on the show.
I appreciate it.
You've been watching Lakeland Currents, where we're talking about what you're talking about. I'm Ray Gildow. So long until next time.